what I wanted to do for the next while is to ask a panelist, and in this case we have representatives from the control programs of Vietnam, of Thailand, of Laos, of Cambodia. I wanted to ask them some questions about how basically, what do you think of what genetic surveillance has delivered so far? What do you think it hasn't delivered so far? And what gaps do you see that probably you wish we would have done things different? And we'll ask then the same question to the funders, because of course that's an important perspective for us as well. So maybe well, since Anh and Tang, maybe you can comment about Vietnam, how you think, what you think about what genetic surveillance has delivered, and what you wish it had done that it didn't do.
Yeah, thank you, Professor Oliver Mioto. Concerning the application of the molecular marker and genetic data come from the GenRe-Mekong. So far, as you know already, GenRe-Mekong project have a support for the National Malaria Control Programme, a lot of data. And we see the data at the early warning system, early warning sign for antimalarial resistance before the TS result. And therefore, if we have a own data from the TS, in vitro, from OCRU and from impact, and especially in the molecular marker result, we have a full data, we have enough data to confirm and to evaluate the wide scale of the antimalarial resistance in Central Highland of Vietnam and in whole country of Vietnam so far. Maybe you know, during COVID-19 pandemic, at the end of the 2020 until now, malaria situation sharply reduction, and we have enough the sample for the TS, but we have a sample for the genetic marker and genetic card, and the data show that about the efficacy of the artesunate pyridine still stable at via the result from Dr. Nguyen, and we are not worried about that, and therefore we will continue to use biomass at the first line treatment for that. And the second thing, on the use case from the result of the Professor Oliver Mioto and from the Dr. Nguyen, so that help us about the gene flow of the antimalarial resistant movement from the first location to another location for us predictive, and to how to prevent about the first breakout of the antimalarial resistance. One, for example, in Phu Yên province, you know, in Phu Yên, it seems to be the way we have not enough data for the TS, but we have enough data for the molecular marker antimalarial resistance, especially the K13 propeller and the plasmapsin and the EXO 415 in the Phu Yên. And we have we submit all the data from the molecular marker from you and from Dr. Nguyen, submit to National Assembly in Ministry of Health. They agree. Here is the early warning sign and replay and update for the national policy for the treatment guideline. I think with your result now and then, GenRe-Mekong Subregion, GenRe-Mekong project help the National Malaria Control Programme in Vietnam foster about the malaria elimination roadmap, not only for the target 2025, but also I think sooner for that. Once again, thank you so much on behalf of the National Malaria Control Programme. I'm very grateful about your support.
Well,
yes.
Thank you for the kind words, but I think Dr. Nguyen and our team have done work, but actually your organization has been very dedicated at doing this surveillance. So you should congratulate yourself too. Can you agree on these comments?
With Dr. Quang, and in my point of view as the staff of National Malaria Program, I think we already have done good things in terms of the detect drug resistance. What I expect more, how faster we have the results in order to help to make decision quicker. The first thing, and the second thing is I don't know about the cost, but I think we have Dr. Iste here with the Gates Foundation. So I think how we can overcome with costs and also with the personnel, improve the personnel in terms of techniques here to collect the sample process and so on. And I really, if possible, we can integrate genetic surveillance into regular malaria program. So we can have full picture of the data. And now in Vietnam, we have 46 provinces free of malaria. And if possible, I really would like to use the genetic surveillance to confirm the area really free or not, because now we base mainly on IDT and also slide reading. And you know that with IDT, we have problem with the sensitivity to detect PV, and also microscopy in some area is difficult to maintain skin of the technician. So if we can use the genetic surveillance in order to confirm free malaria area. So that's my, maybe I'm wrong. Correct me. That's the.
I can see Nguyen making notes.
Yeah. So I completely agree with Dr. Quang, and I also give my some opinion.
Excellent.
Thank you.
Excellent.
Yeah.
Thank you very much. Dr. Siv, would you like to comment about Cambodia?
No, first of all, thank you for joint collaboration and the effort of the project, and also provide some information to the country. It's even important. I just only say some gap that we need to thinking how to improve. But one of them already raised by Tang here. How can the increase frequency of the data come to the country in order to use it? But I know that there is a implication on behind that in terms of increased fund for analysis, because you need pooling. If you are not pooling, you do less sample, even you pay the same amount of money by using the reaction by analysis. And also in the same time, country need to frequent send the sample, let's say every month. Even we have few sample, you have to send every month to the group. So this is lead to increased frequency of sending the sample rather than waiting for 3 months and we pull something. You don't want to waste money for that. But this is you need to thinking about, because not only the technical part, technical much more easy, but you have to invest more money on that. So this is the one that country want to see more data come more frequent. And at least I have been already comment that at least you looking for where is the high burden of some area that you need to select it frequently, monthly doing, even waste money. But the information from that burden area is very quite important, because some country they call outbreak, but my country never call outbreak, we call the high burden area. And the other thing, and also the one to link to Dr. Tan, something about so we consider all the sub microscopy or RDT. Currently, we not collected. We collect until they are confirmed positive. We collect the sample here. But how about subclinical, that they all have parasite in their body, but they are not. We are not intend to collect them because there are no sign and symptom. We cannot provide diagnosis test to them and to confirm. So is there a way to collect some like 10% of negative sample in each area? So which are blank collected. If individual is happy to join the study, we collect the negative sample. But send here you can analyze whether there is a parasite positive negative, because there's no way to identify by microscope or RDT. You need to do PCR. Even country can do it, but waste time. Just collect it and send here. You confirm yourself and do something. So we have more idea about the low burden area that still resistant is the marker around, ranking around, or they are start to lower on something. Thank you.
I think you made Dr. Nguyen very happy here, because she's been thinking about that for a while now. And it's definitely one of the things that we've been discussing. Yeah, thank you very much for that. Dr. Keo, would you like to comment about Lao, please?
Yeah, thank you so much. Again, for the Lao PDR, like we have the stratification to like eliminate area and burden reduction area. Is burden area we have the activity like to surveillance drug resistant, surveillance about the prevention of ESW, because we concerned about the imported case. Like we know another nearly my country, we use different anti-malaria drug, right? For example, my country first line we use AL, but Vietnam, Cambodia, another. If the case from outside come to my country, how about the anti-malaria drug in Lao PDR can treat or not, or curate 100% or not? For example, last month we have the import kit from Kenya. Yeah, very difficult to collect the blood sample because they don't understand about the national strategy. They avoid our team to take the blood, but we want to know like you know, we collect the zero, right? We want to know the resistance, we want to know the K13 and gene, another species we want to know, but finally cannot. And second case from Papua New Guinea also. I saw for the imported case, they not collaboration, they not participate for us. But for the indigenous case, like they go anywhere, yeah, from go to Vietnam and then back. But we surveillance because we concerned they carry parasite outside come to our country. Yeah, we know for the operational research really hard work. Yeah, to get information for us, like recommend for us to policy maker to the make the national strategy plan. Yeah, like how to update the treatment, how to surveillance for the drug resistance, because your information show go anywhere for the drug resistance. Yeah. This is we try to how to say the policy maker to protect. If however government fund support us for like a prevention anything, but for the drug resistance, like not easy but not difficult if our team can good surveillance. Yes, this is our concern.
Dr. Rugiringan, Thailand is just starting this surveillance activity. So in your case, I would like to ask you, what are your hopes for it, and what would you like to get out of this genetic surveillance?
I think for our country, before I just make a comment anything, I want to tell you that your program is really benefit for our country. It's clearly about the benefit. However, we have many like process for make the data and send the sample to you, right? That if all of you see in the morning, you can see in the Thailand we have low data in the map because the project is maybe cannot move on because we have the many like the problem challenging about the process for send the sample, legal and many documents. Okay, no need to tell about that. Oh, okay. For our country, we move from the TS to the integrated drug surveillance by we try to monitor all of malaria case in our country and try to follow up the drug efficacy in our case. However, okay, we can follow up many cases, but the sample that we can collect only 10% of that because we have many systems for the people when we go to the hospital, go to the malaria clinic is separate. So we cannot control the sample come in to our laboratory. Okay, that is the challenge for us, not your program. Your program, that's okay. However, we want, if the next time we want to have more data about the YWAC, that is already in Thailand more than 95% is YWAC. So nowadays we have many samples of the YWAC in our laboratory, but we cannot to use that for give some information in the drug resistance. We know only in the clinical trial, clinical monitoring, we still have high efficacy. That means when we follow up day 14, 28, and 60 and 90 is clear parasite in patient. and but we cannot to know about the molecular exchange or not. So in the next time, I think we want to give more about information about the YWAC, and also we have the problem about the new. I not mean the new. That mean the other species like the PM or PK like the other country to know about the duck resistance also. Yeah, that I think that is all.
Yeah. Well, thank you. Well, thank you for your very candid observations here. And luckily we have the VIVAC screen here, we heard earlier on. But yeah, I mean, one of the major things that are going to happen in the next few months is the implementation of a VIVAC panel, so we can tell you more about this. So you'll hear more about this in the afternoon. And hopefully, as you know, with VIVACs, we don't really know very much about resistance markers and things like that. But what we are hoping is to be able to conduct at least some genetic epidemiology, some ideas about gene flow and so on. Okay, thank you very much. Sorry,
I have just a little bit information for the other country, right? The Cambodia, Dr. Sif comment in the morning about the high burden province in the court with the Myanmar border, something like that. That's concern about the duck resistance or not, or something like that. We follow up, like I tell before, about the clinical trial. We found more than 95% is still clear parasite. Yeah, that's kill. No.
Okay, that is good. But undoubtedly, it's kind of hard to predict what to expect in that region as well, right? So, because we have no control, you have no control over it in many ways, right? Yeah. Okay. Could I ask you for some comments? So now this project has gone on for several years. I'd just like to know from you, well, what do you think of what's be kind? What do you think? No, but more than anything else, also, how does this fit in with the expectations of the foundations and the strategy generally of how you would like, what you were hoping that your investments would produce here?
Great. Well, thank you very much, Oliver, for inviting me to attend this meeting. It's really wonderful to be here and to meet people from all of the different countries. I've heard a lot about you over the years, but obviously hadn't had the chance to meet. First of all, I'd like to say that the GenRe-Mekong project was one of our first investments in malaria molecular surveillance and remains a flagship investment. It's a really great collaboration between the countries of the Greater Mekong Subregion, and really shows the benefit of using a regional approach to tackle antimalarial resistance. It's clearly demonstrated the benefits of genomic surveillance as an early warning system for antimalarial resistance. And you've clearly articulated here that the resistance markers that are discovered obviously require validation with clinical efficacy studies and ex vivo and in vivo studies in order to inform decision-making by the NMCPs. So I think many congratulations to all of you for the work that you have done over the years, for the data that you have generated, and for the impact that you are having, not only in the region, but also globally. People are very much looking to what you have done to inform what to do in Africa, as anti-malaria resistance is appearing in different countries in Africa. And I think they're beginning to realize that they're going to need a regional rather than a national approach to tackle this. So all good. I just thought what I'd do is I would reiterate our strategy, because I think our malaria molecular surveillance strategy is relatively recent. And really our focus is to build capacity for genomic surveillance in malaria endemic countries. to address the key epidemiological use cases, primarily antimalarial resistance, but also HRP23 gene deletions in countries where that is a problem, and also distinguishing local from imported cases in elimination areas. The projects that we fund tend to demonstrate strong connections with the NMCPs. So we like the NMCPs to be involved from the outset, because you are the people who know what the problems are and what the needs are in your country, but also any data that are generated should be made available to other people who can make use of the data and to help you to analyze it and make best use of it. Our strategy over the last 3 years has been to try and diversify our partner base, and we've been increasing funding directly to LMIC grantees. So just to give you some figures, the number of investments has increased from 4 in 2000 to 43 investments as of this year. And over 60% of these are now going to malaria endemic country grantees. And in fact, over 30% of them are going to teams that are led or co-led by women. We aim to invest across different scales. So individuals, we have some small grants that go to small laboratories for about $100,000, to larger projects, technical partners and networks. And the data that are coming out of our projects are being used by NMCPs to inform decision making. So for example, in Ethiopia, it led to a change in their RDT policy, and in Rwanda, it's resulted in changes in drug resistance policy. The other thing that we're very well aware of is the importance of considering vulnerable populations. So looking at the people that suffer from malaria, and also addressing sort of gender equity issues. We also leverage a convening budget to organize meetings that enable people to come together and build an MMS community. And we also work with a number of international partners such as Africa CDC, WHO, President's Malaria Initiative, Global Fund, FIND, and UNITAID to try and sustain support and amplify the impact of our investments. So that's kind of, in a nutshell, our strategy. But there are a number of challenges. So obviously we are doing our best to build capacity in endemic countries, but there are a lot of countries that don't have capacity. Most of the capacity has been built in academic labs, and really we need to think about how do we transfer that to national public health labs? How do we support regional reference or training labs so that countries can learn by going to a regional lab for training and bringing that technology back to their own country? Procurement of equipment and consumables is a nightmare in malaria endemic countries. It's slow, it's costly, and that is a big problem. So in the past, a lot of people have relied on northern partners to do the procurement and the shipment. That is not going to work forever and ever. We can't be importing consumables and suitcases for the next decades. As data are generated in country, one of the things that has become an increasing challenge is data analysis capacity. So it's nice to see that online training courses are being developed, that user-friendly web applications are being developed. And I think that will really democratize MMS in endemic countries. One of the things that Oliver mentioned was data standards for malaria genomic data. So we're very well aware that many groups are generating data around the world, but at the moment, there's no easy way to share and to aggregate those data. So we're hoping to do a piece of work on that in the coming year. One of the points that has come up time and time again is timely data sharing. So, if genomic data are generated, they need to be fed back to the National Malaria Control Programs and the Ministries of Health, ideally within a year of it happening, not 2 or 3 or 5 years later, so that countries can take decisions to change their policies if need be. And there's also a need to share data internationally. So, for example, with the World Health Organization, if you start detecting new mutations in different countries, it's really important for the WHO to know about that. And at the moment, it seems that it's kind of a bit random, as to whether people do share those data and when they do. One of the things that comes up time and time again is the conflict between data release for public health benefit. So, you know, ideally that should be done within a few months versus for academic publications, which can take, in my experience, up to 5 years. Some of the really high impact publications that have come out are from data from 2018 were published in 2023, and that's really not great for public health purposes. I'm really there. Finally, there's a need to translate MMS into routine surveillance for public health. And this is something, again, that many of you have mentioned today. Many of the protocols have been developed in academic labs, and this is great, and everybody loves their protocol, but we need to think about how do we simplify them so that they can be used in public health labs. How can we make sure that the turnaround time for genomic data is timely so that actions can be taken? And then last but not least, I'll finish with the point most people think that funding is the biggest problem that they face. And this is really something that we do need to address, both as a foundation, but also as a broader MMS community. Obviously, we've funded quite a lot in the last 3 years. A lot of catalytic funding to set up malaria genomic surveillance capacity. But we need to think about how do we make that sustainable and affordable in the long term. And I think that there are a couple of mechanisms we need to think about. One is to get MMS into national strategic plans, to say that it's really important to have this capacity in country and have it funded. Secondly, we need to think about it, you know, once it goes into the strategic plan, you can then ask the Global Fund to give some money to support genomic surveillance. And then the third issue is also the need for domestic funding, I think. So academic, you know, grant-making philanthropic organizations such as the Gates Foundation and the Wellcome Trust are very good at the setup side of things, but we can't fund MMS forever in every single country. On that note, I'd like to thank you again for inviting me to participate in this meeting, and it's a great pleasure to be here. Thank you.
Thank you very much. Thank you. If I could just make a couple of pick up on a couple of points that you made there. So about the capacity building, which obviously has been a big concern for us as well. I think your point about the data analysis is actually, I think, sort of a bit of a thorn in my side, because I think in the region, we've been able to engage very well with the control programs to the point that they're actually doing advocacy at higher levels in their countries for us now. And we've been able to do good capacity building with the laboratories. We have wonderful laboratory partners, but we do find it very hard to find people in country that can work on the data analysis. And I think this is not just a problem of willpower or whatever. It's also a thing. It's also about malaria not being probably such an attractive field for young people to be engaged in, and so on. So I think there is a really fundamental issue here that I'm not sure I have figured out yet how to address. Okay, so that's one thing, and then the other one I can't remember. So I think it's time to lunch. So we have. Then do we make it now? Okay, 1:30 exactly. So we take an hour for lunch and reconvene here at 1:30.